But today's presentation is on Cymbalta or duloxetine, and we'll be walking through the standard approach with the hyperbolic tapering approach, and then getting into Cymbalta specific facts. And then we are delighted and honored to have Bryan Shapiro also talking about his research on Cymbalta, which would be really exciting. And then we'll have some time saved up for the Q&A. I have a slide that's also laying out the agenda so that we can see everything. But with that said, I think it's just about time we get started. What do you say, Bryan?
Let's do it. Emma. Alrighty. So welcome to everyone, and thank you very much for taking the time to discuss Cymbalta, one of, in my opinion, the most difficult and most challenging antidepressants to taper. But my goal today is to reassure you that this is definitely possible with some support. A little bit of an introduction. My name is Bryan Shapiro. I am a psychiatrist, board certified, living in Orange County, California, pretty close to Disneyland. I'm a assistant clinical professor in the Department of Psychiatry at UC Irvine, where my primary role is a mix of outpatient practice, consultation liaison psychiatry. I train the residents in psychopharmacology. I'm also involved in a nationwide program where I train primary care physicians on responsible prescribing of psychiatric drugs. For several years, I've done some research related to antidepressant withdrawal and better understanding mechanisms and etiology, and why, which was the original question that piqued my interest, is why studies were showing that even tapering did not help patients successfully wean these drugs versus abrupt discontinuation. And so that piqued my interest and led me to do some studies related to the PET radioligand imaging data, and that was furthered and extended by Mark Horowitz's work. I personally have experience on having taken Paxil at a very young age, as well as Lexapro. So I'm intimately aware of the experience of withdrawal and how that can impact all aspects of your life, and it can be a very significant challenge. So. Also pleased to be joined today by Emma. Emma, can you introduce yourself?
Yes, I can. I'm also hearing in the chat that people can't hear me very well. I tend to speak pretty softly, so I'll raise my voice a bit. I'm not yelling. It's a pleasure to be here. I recently joined Outro. I was previously working as a rare disease biotech consultant, but I've always been fascinated and really invested in safe medication practices, especially around depression and anxiety. I, like Bryan, was similarly affected by the medication cascades, early prescriptions in adolescence. I had a pretty difficult time myself with Cymbalta and found myself on the FDA regulated maximum for a while. I experienced pretty severe paraesthesia. This was all as I was getting into college, so it was a turnabout of events, but I was always inspired, and it really drove me to better understand how clinical research can better represent like real world use. So for instance, the medication cascade of getting put on different medications to treat a side effect from the original one, rather than, looking into whether or not the first medication is the right fit. Being at Outro so far has been really exciting. Like I said, it kind of all started when I was in college. I was studying neuroscience. I actually came into college to study painting. And then after my personal experience with antidepressants and anti-anxiety medication, I found myself with a full schedule of neuroscience classes and bioinformatics classes. And eventually my counselor sat me down and said, "You don't have the credentials anymore to graduate with an art degree, but you're pretty close to neuroscience, so why don't you just go for that?" So working here has been part of this amazing journey of better understanding myself and how we can help people similarly off-ramp from these medications. So I'm really excited to be here. And also just to let everyone know a bit of my role here on the webinar. Bryan will be doing the majority of the presenting and speaking. I will be moderating in the chat. And I also want to let you know that I'll be tracking some questions in the chat as we go through the presentation. That way we have a roster of some really good content for Dr. Shapiro to cover at the Q&A section at the end. So with that said, I think we're ready to get started. So just a quick overview of what we're going to be covering. I've set it up into a couple of sections here, but why do people want to stop antidepressants? So going into the cases where, they just want to experience life off medication, they or experience a lackluster of colors and feelings and emotions, and they want to see what it's like. Or perhaps they've been on medication for so long that and burdened by the side effects that they want to know if they're empowered enough now that they have the other fundamental needs satisfied, be it with therapy or with support from their family or situational events where they feel stable enough to explore discontinuation. Then we're going to hop into withdrawal symptoms and how hyperbolic tapering helps minimize the withdrawal symptoms on the tapering process. And then Dr. Bryan Shapiro is going to help us get into the nooks and crannies of Cymbalta specifically, get into the details, and also get into a bit of a review of his research on Cymbalta specifically. And like I mentioned, we'll have a couple of minutes, 10 to 15 at the end for Q&A specifically, but then I encourage you set some questions up in the chat in the meantime.
Great. Thanks for the introduction, Emma, and for the explaining our agenda for today. I didn't know we were both neuroscience majors in college, but that's pretty cool. Going into deprescribing and why we do this. What are the reasons why deprescribing is important for patients? So we have some data from the CDC that's basically suggesting that 7%, this is a tremendous number, 1 in 14 adults in the US have been taking their antidepressant for 5 years or more. There's also some recent data from last year showing that the median duration, or like the middle amount or duration of antidepressant use in the US is about 5 years. That's just median. And this is in stark contrast to clinical studies, like clinical trials that have examined withdrawal symptoms in the past are basically typically under 12 weeks. That might have been one reason why withdrawal risk has been kind of underestimated over time. And it's kind of a segue, but wanted to just mention that. So patients, there's often this, as a psychiatrist, I see this among the residents I train, and it's pretty pervasive. It's just clinical inertia. So once a patient is started on an antidepressant, as long as they're doing well and doing fine, it's just sort of set it and forget it and left on as long as they're doing okay, without any real discussion at the stage of informed consent, but also over time during the treatment process about the off-ramp or the timing and when it's indicated to get off of the medication. Many people, they feel like they don't need this medication long-term. Sometimes this medication is prescribed for a reaction to acute stress, and then patients' circumstances change. Maybe they make progress in psychotherapy. Life is much different. They don't really need this medication anymore. There are general guidelines from authorities like the American Psychiatric Association who make recommendations of not exceeding 6 to 12 months after a single major depressive episode. Those are out there, but that is also kind of in contrast to typical practice patterns of discontinuing these medications long term. Polypharmacy. It's very common, at least in speaking in my community or just in the larger United States, of just patients given a number of different labels: ADHD, GAD, MDD, OCD. And for each of those diagnoses, getting put on another psychiatric medication. And it's not uncommon for me to see patients who are misdiagnosed who present on 6, 7 different psychiatric medications ranging, addressing issues ranging from sleep to mood to ADHD to medications that are aimed at addressing side effects of the other medications. This is all very common. In my practice, patients often wonder what life was like before their medications or what they felt like because they experience these insidious, subtle, but increasing side effects that are kind of difficult to put a finger on. But very often it kind of is captured by the notion of emotional blunting or numbing, where, maybe the lows don't feel quite as low on the medication, at least for some time. But also the highs don't feel quite as high. Things feel blunted, gray, things that normally would cultivate, joy no longer has that effect. And, kind of hand in hand with that emotional numbing is sexual numbing, which can be very problematic for patients, difficulty achieving orgasm. These are things I talk about openly with my patients, can be very problematic. And so there are also idiosyncratic kind of side effects. Patients perceive a lot of weight gain or changes in sleep, changes in energy, just as low-grade fatigue. These can vary depending on the antidepressant we're talking about, but can be a pervasive issue. There's also sometimes there are medical drug-drug interactions that are also that are critical. I've had several patients on tamoxifen for breast cancer prophylaxis, for whom their Prozac or Paxil might actually interfere with the efficacy of that medication in preventing the recurrence of breast cancer. So there are sometimes clear medical reasons why these need to be tapered or discontinued. And we care specifically about at Outro, like the specific concerns of our patients and why it's important for them to get off of their medication. Many of whom are just concerned about long-term effects, not even effects that have necessarily manifested yet, but concerned that if I take this medication for another 10, 20 years, I'm reading these theories about things like tardive dysphoria or the potential for these medications to promote and perpetuate underlying depressive tendencies over time. That is something that's a common concern. Not wanting to feel tethered to a medication. So the experience of waking up and feeling like you need to take your medication at 8 a.m. because if I take it at 10 or 11 a.m. or if I wait a few hours, I'm going to feel it. It's you feel like it's kind of like a ball and chain kind of thing, and you maybe you miss a dose of medication or you forget when you go on vacation, maybe you go overseas, and how are you going to get your Paxil from a pharmacy over there? You feel tethered, and that is a very common reason why folks wonder about getting off of their medication. We talked about unpleasant side effects, just very, very common. Wanting to try alternative complementary approaches, psychotherapy-focused lifestyle interventions, and also just a sense of tolerance to the effects of the drug. And there can be this disconnect where patients feel like it's no longer helpful for their mood issues, but they're also experiencing persistent side effects, which is kind of a cruel combination. So we see those as well. And this is data we kind of gleaned from. We're constantly collecting information about patients because Outro being so novel, it's an opportunity to actually generate original research that we can analyze and help promote these findings. And so what do patients do? Because clinical guidance is sorely lacking. There are no formal clinical trials that look at hyperbolic tapering or new methods of tapering to help patients get off of these drugs. The guidance from the APA, for instance, is extremely sparse. They can say things like, we recommend a gradual taper, but it's completely vague and not specific to each and nuanced to each individual antidepressant. And so this has happened time and time again. A patient, goes to their doctor. They maybe had stopped their Paxil by the direction of their physician, not necessarily even a psychiatrist, but primary care physician. They develop these paresthesias or these strange symptoms. The physician does not recognize this as potentially being withdrawal, and then subjects them to unnecessary medical workup, referral to a neurologist, which can take time, and this leads to missed work days and an incredible level of distress. Patients, of course, turn to these online peer support communities, where very impressive in terms of the nature of the quality of the information that's kind of been aggregated by people like Adele Framer has led Surviving Antidepressants. We have Maria Pastor from Cymbalta Worth. Basically a grassroots movement to help patients get off of these drugs safely, because this guidance is not being passed. It's not, you don't see it in the package inserts, you don't see it in guidelines, and you don't see it being discussed from the physician to the patient. And so what are the factors that increase risk of withdrawal? Why is it so challenging? And who who and experiences it and how many. At least 50% experience withdrawal. The incidence is it's hard to approximate because, as I mentioned earlier, clinical trials are typically less than 12 weeks. These are like the pivotal studies that are done when a drug is in the process of being approved and going through phase 1, 2, and 3, three studies. But as I mentioned earlier, people are on these medications for months to years, average of 5 years. And so based on observational data, some surveys, we find an increasing but kind of not asymptotic, but kind of hyperbolic and plateauing curve where patients' risk of withdrawal can increase linearly initially, and then kind of plateaus after about 2.5 years, where the longer you're on these drugs, the harder it is to get off, which is the real problem with this clinical inertia of just keeping the patients on medications long term. It can be very severe. So there was one meta-analysis claimed that the risk of severe withdrawal symptoms was about 50%, and these kind of better capture the long-term users. But it's very individual. I'll see in clinic, and this is the tricky part, is that some patients I've seen they had no issue in the past getting off of these drugs, and some patients have an absolutely tremendously difficult time getting off of these antidepressants. So there is a lot of individual variability, and that is why these tapers need to be personalized.
No, just a quick question or point from Celeste in the chat. She wrote 50% of people have withdrawal. I think this doesn't take into account the people that have delayed or protracted withdrawal reactions. I think that's a great point that I just wanted to raise to the audience. And also, Bryan, if you had any commentary on it.
Yeah, correct. And that's the thing, is that very often the measurement time, the time when withdrawal symptoms are measured in these studies, is a week or two. They don't account for patients who experience delayed onset withdrawal symptoms, and protracted withdrawal is extremely understudied. So that is a very good point. There are a lot of limitations to this data. What the percentage really is not that, whether it's 50 or 60 or 40 or 80% is really not important. And I think misses the issue of like how distressing this can be for vulnerable patients. As I alluded to earlier, many physicians, like they misattribute withdrawal symptoms to relapse. And so one of the clues that you're experiencing withdrawal symptoms versus relapse, of course, there can be mood changes, but physical symptoms can be a clue. One of which that is actually quite specific to serotonin withdrawal, and that's kind of what we're speaking to mostly here, because when we say antidepressants, that can span non-serotonergic agents, but most commonly it's patients taking SSRIs or SNRIs. These brain zaps, these electric shock-like sensations that feel like they're happening from inside your head, and that's worsened on movement typically. That is something that is very specific, I think, to serotonin withdrawal, and very often goes undetected or is misattributed by physicians. These symptoms can last weeks, months. We've seen these lasting years. Typically, the patients who have more protracted symptoms and the patients who have long-lasting symptoms are ones who are not only vulnerable, but tended to who reduce their medication far too quickly or even abruptly, and that can sensitize the brain and to cause a lot of these more severe issues. We see, I did a paper trying to establish core symptoms of acute serotonin reuptake inhibitor withdrawal: dizziness, irritability, agitation, brain zaps. These are very, very common symptoms reported in nearly all patients.
Mary in the chat asked how you would identify internal tremors across the discriminatory symptoms, what that might look like.
Internal tremors. So the first thing to know is that these symptoms can be very idiosyncratic and very individual. Because serotonin, for instance, is an inhibitory neurotransmitter, withdrawal from serotonin reuptake inhibitors can lead to overexcitement and overactivation of neural circuits. So basically, any and all symptoms related to hyperactivity of the central nervous system are possible, which means that an open-ended question to the patient about how you're feeling and how are you doing off of your medication or since you've reduced, it's important, rather than to rely on just checklists, to actually ask the patient their personal experience in terms of how they're feeling, because they may not be captured on a checklist. And then lining that up with, because you're trying to establish an association, right? Making sure that they're temporally related, that these are more likely related to stopping the antidepressant. This is all. Acute withdrawal symptoms can also, classically, they resolve with reinstatement of the medication within hours. But in some cases, particularly patients who have gone on their medication, off their medication, on, off, or have made, or particularly vulnerable, sometimes it takes a while, a month or two, sometimes to restabilize after reinitiate a dose. And we'll talk about that in a little bit more detail a little bit later. Okay, so hyperbolic tapering. Because what was done before, right? This is the issue, is that, let's say, we have, many of you might know of the medication Zoloft. And so what you might see in practice with a psychiatrist or primary care physician, patient's been on 200 milligrams of Zoloft, which is the maximum dose for, let's say, 2 years. The physician tapers them from 200 to 150 to 100 to 50, which is the minimum therapeutic dose, over several months. Physician feels like, okay, we've tapered for 3 or 4 months. We've attained the minimum dose. Let's stop cold turkey. And the evidence here, and like the connection that was made by myself and also by Mark, basically claims that this was not even close to slow enough to prevent withdrawal symptoms. The changes should not be kind of linear, meaning you should not go like reduce by 10 milligrams every month. It needs to be hyperbolic or percentage based, where you reduce by a set percentage, whether 5 to 25%, carried forward at every dosage interval change, like every 4 weeks. And so, complicated graph is basically just to illustrate the point that you have the level of antidepressant in your blood. You have a homeostatic set point. It's like where your body is used to in terms of exposure and where its comfort level is. The point is that you don't want a sudden dip, a massive drop in your set point, your comfort level, or else you're going to experience a lot of withdrawal symptoms. You want to slowly, gradually. You don't want to destabilize your set point too much. You want to slowly reduce, let your body adjust for 4 weeks. Slowly reduce, let your body adjust for 4 weeks. That can be much better tolerated, and prevent some serious problems in terms of withdrawal symptoms. Okay, so great. There was a very interesting discovery. This was work from Meyer et al. In the 2010s, establishing that after the fact, after these drugs were already marketed, that the minimum therapeutic doses, so like the minimum dose that's claimed to be effective by the FDA, has 80% of an effect on its main target, the serotonin transporter. And the corollary of that is that doses that are below the minimum therapeutic dose are necessary in order to taper these drugs safely. And we are talking about Cymbalta today, so let's hone in specifically on what that looks like for Cymbalta. Does anyone know? Does anyone know that the lowest available dose of Cymbalta? It's just 20. It's 20 milligrams, and that might sound small, but 20 milligrams of Cymbalta taken daily has about a 70% effect on its target, and that's just one of its targets. 70%. Meaning, if you were to stop this lowest available dose, this is the lowest dose. It's not a tablet that you can split or score or anything like that. It's as a capsule. You are going to basically jump off of a 7-story cliff, as Mark might say.
He does, yes, typically.
Yes. And the other part of it is that, let's say you're under the care of a pain physician or a psychiatrist, and they're like, okay, we reduced from 120 to 90 to 60 to 40 to 30 to 20. We made it. That's 6 months. We're at the minimum dose. You stop that dose, you really haven't made that much progress. So the
hard part hasn't happened yet.
The hard part hasn't happened yet. So it's not intuitive, but it's real. It's very real. And that's what Mark and I both learned from this very interesting brain imaging data. So this is kind of the fun part is talking specifically about Cymbalta and some why I think it's the hardest antidepressant to stop, but doable, but very hard. When you think about withdrawal risk, one of the factors that increases risk is the number of receptor targets, because if you have more receptor targets, you're not necessarily just withdrawing from serotonin, you could be withdrawing from other receptor targets too. And for Cymbalta, that's norepinephrine. It could be a little bit of dopamine, but another one is actually sodium channels, potentially. So sodium channels are these little proteins that are expressed in peripheral nerves, so nerves in your peripheral nervous system, but all over your body. Withdrawal from sodium channel blockade can cause symptoms that are a little bit more specific to Cymbalta, including paresthesias, so tingling in your extremities, like hands and feet, or even truncal region. It can cause burning and a tingling sensation because of withdrawal from these sodium channels. Norepinephrine withdrawal might incur additive risk of like fatigue in withdrawal and hypersomnia. There were a couple we call pharmacovigilance studies, so studies that are done to survey the effects of a drug much later than when it was approved, to look for kind of signals of certain side effects or risks on a larger epidemiological scale. Because traditionally, when in residency, it's like Paxil and Effexor are the ones that are usually like, these are the high risk ones. Everything else is okay. But two pharmacovigilance studies, one of which from the WHO, one of which from the US FAERS database, showing that duloxetine and venlafaxine, paroxetine, and desvenlafaxine, those four are the highest signals for withdrawal. They even showed that buprenorphine, which is a partial mu-opioid agonist, pretty hardcore medication, had a similar risk as these four antidepressants. We talked about variability in terms of withdrawal risk. I mean, right, the short-term studies will show a low rate. Longer-term studies will show correctly much higher rates of withdrawal. And so what is it about Cymbalta that makes it such high risk? It's, first of all, in addition to all the receptor targets, it's the pharmacokinetics. It's the half-life. Paxil, for instance, paroxetine, has a half-life of 21 hours. Half-life being the amount of time it takes for about half the drug to be cleared from the body. So the longer the half-life is, the slower the medication kind of leaks out of your body. With Cymbalta, it's just 12 hours on average, which is comparable to venlafaxine and desvenlafaxine, but actually significantly less than Paxil. That is very short, which means that, man, if you're 2 hours late on taking your Cymbalta, even then you may have issues. We also talked about the formulary. Many SSRIs, for instance, most SSRIs are available in a liquid formulation that's commercially available. Cymbalta is not. It's not available as a tablet that you can score. It's only available as a capsule. So that can be a major issue. In terms of tapering options for Cymbalta, this is a very important topic. It's like, how do we taper this drug? There is one final kicker, one final reason why Cymbalta is the hardest antidepressant to stop, and that is a unique pharmacokinetic property of this drug. It's what's called acid lability, meaning if you were to give just the duloxetine powder to a patient, it would be broken down in their stomach and it wouldn't actually reach the blood supply and actually exert an effect, which means you cannot turn this Cymbalta into a liquid formulation, which is so much easier than what patients often have to resort to. So we talked about the online peer support communities, Cymbalta hurts worse, surviving antidepressants. What patients often do, and this actually goes against FDA guidance, but what else are you supposed to do, is they open the capsule and start counting or weighing beads. And I wanted to take a little bit of a moment to highlight that process, because duloxetine capsules, the generic ones, they come in two flavors. You open up the capsule, it either has like 100 to 300 microbeads, and each little bead is what's called enteric-coated, which makes sure it gets delivered to the blood supply without being broken down. Or they come in what are called micro tablets, which are 5 milligram kind of larger pellets. And so just really getting detail oriented here with these larger tablets or mini pellets. In a 20 milligram capsule, you'll have 4 5 milligram ones. In a 60 milligram capsule, you'll have 12 5 milligram capsules. Or you might get one where it's just hundreds of little beads. And so what do people do? What do folks do? And what do we recommend at Outro? By the time we see patients at Outro, some of them have had experience opening the capsules and weighing beads, which is one route that I recommend. Basically, they use these precision weighing scales with like a metal plate that they can use to weigh and weigh the Cymbalta beads, and they'll reduce by a certain percentage every month. That's something that we can do. Mark recommends, kind of repackaging these into gelatin capsules that you can get or back in the original capsule, because some folks get a little bit of throat irritation if they were to ingest the little microbeads themselves, but worth trying. I think most folks won't have that issue. What we offer at Outro is another option, because you can imagine how time intensive that is to taper over months to maybe a year or more of opening a capsule, using a little a tweezer and making sure you weigh the right amount of beads. Is we can use a compounding pharmacy that has an enteric coated capsule, so they can source the bulk duloxetine powder, but these specialized compounding pharmacies, the capsule itself is enteric coated and resistant, so that the overall exposure is the same as if you were to just open up the capsules and ingest those enteric coated beads. So that is one much easier way to taper Cymbalta, because you cannot compound this as a liquid, and that is a major issue. I think about people with physical limitations, cognitive limitations, who don't have the ability to do that very precise and meticulous process of weighing or counting beads. Some people use rulers to kind of lay out the beads individually, and you can imagine how intensive that is. So we offer compounded capsules at Outro.
I also just want to take a moment to recognize in the chat, people are talking about the bead counting and what you just mentioned too, the burden that's now posed on a patient that's interested in exploring life off medication is confounded by how difficult it is to go every morning or every night and count those beads, especially if you're going through the withdrawal period, or for instance, if you're on such a high dose and you have the tremors or the shakes, and it's just difficult to stay concentrated, have your body work with you as you're counting out that process every single day. It's a good call out.
That's exactly right. And you can imagine someone who has no psychiatric history, who was prescribed Cymbalta for chronic. It has the indication, by the way, not just for mood disorders, but for various chronic pain states: diabetic peripheral neuropathy, chronic musculoskeletal pain, fibromyalgia, and they're much less likely to get informed consent. These patients might be more likely to have a lot of physical limitations, and it's just not feasible to do these very involved processes of weighing and counting beads for many months. So what about the pace of the taper? What are some options? And I'm sourcing this from the Maudsley Deprescribing Guidelines from Mark Horowitz. You have a few options in terms of fast, medium, and slow. We'll go over this relatively quickly. But what I wanted to kind of impress is that as fast taper, we're kind of reducing by degrees of SERT, or the serotonin transporter, the target, its occupancy, the effect on the receptor over time. And so if you want to do this relatively quickly, you can start fairly quickly, right? Because the dosage, the effect on the receptor is pretty marginal within the therapeutic dosage range from let's say 60 to 20, and you want to go a little bit more slowly as you go down to a subtherapeutic dose. This is a relatively fast pace. This will take 10 or 11 steps. At 4 weeks each, this will take about a little less than a year. Slower pace involves 5 percentage point SERT reduction. I like to go slower with Cymbalta, and the reason is because we're not only worried about serotonin, we're worried about norepinephrine, we're worried about the sodium channels, and that can have different, not to get too sciencey, but different dose occupancy curves with respect to those other receptor targets. So we can do a moderate pace. You can see that these take a little bit longer. We can go a very slow pace. These are patients who are very, very vulnerable in terms of withdrawal symptoms, where we stop at a receptor occupancy or an effect on the serotonin transporter of about just 2%. And it's not unusual to need, if you're wondering, dosages less than 1 milligram a day to fully stop this medication without any major issues. And this can take some time, but you think patients on Cymbalta for 10 years, which is not unusual at all. I think it should not be viewed as abnormal to need well over a year, even 2 years, to taper off this drug successfully. And one of the ways that we approach this at Outro, when we're in our clinical rounds and we're discussing, okay, this patient has been on this drug for 15 years, they've had a terrible time with withdrawal in the past, how can we help this patient get off Cymbalta successfully? We often stratify patients. Usually for Cymbalta, we're certainly medium or high risk, and not unusual at all to need 2.5% or 5% Q4 week, my term for every 4-week reduction in their Cymbalta dose over time. And we do make these reductions, it's carried forward. So it's a very slow process, but this isn't necessary for most patients.
Bryan, can you go back and explain again what you mean by carry forward? Because I think also for the practice of hyperbolic tapering, it's a pretty big question that we got in our Q&A section for Mark's presentation.
Of course, and I'm sorry to gloss over that. So let's say you're tapering a patient off 10 milligrams of Cymbalta. So a 10% reduction would be reducing from 10 to 9. But at the second phase, at the 9 milligram dose, we would do 10% of the 9. So instead of doing 10% not carried forward, which would be 10, 9, 8, 7, 6, we would do 10, 9, 8.1, 7.2, etc.
That was a great explanation. If anyone has any more questions for clarification, just drop them in the chat and then we can cover them in the Q&A.
All right. So I recently, this is in press, recently with my good friend from USC, Daniel, we've noticed this is why Outro is so interesting, is that we get to kind of be at the front end of like all of these interesting observations and discoveries, and the ability to take these observations and disseminate it more broadly, both in the scientific literature, but also in the press and the media. We've found a number. Basically, we summarized a number of these unique features of Cymbalta that make it a unique challenge for patients, specifically patients who have a lot of physical and cognitive limitations. The FDA guidance is incredibly sparse. It basically says if patient experiences withdrawal symptoms, restart the original dose and go more slowly. It does not address the fact that even the lowest dose is almost impossible for vulnerable patients to stop abruptly, right? There was a huge series of lawsuits. Actually, Eli Lilly was successful about the lack of informed consent and the downplaying of withdrawal risk with these drugs. But I think what these lawsuits, what was missing from the prosecution was that even if there was sufficient informed consent, it doesn't touch on the fact that there is no FDA approved way or method or methodology that's suggested to safely get off of these drugs. So at Outro, and I've already kind of discussed this in detail, which is we overcome this limited formulary by either working with a patient who might be familiar and might be comfortable opening the capsules and counting beads. But we also closely align with compounding pharmacies that enable us to overcome that unique acid labile property of Cymbalta to compound this drug in a way that should be equivalent to opening and counting beads. And just as a word of caution, if you're compounding this on your own, with your physician, if that Cymbalta is just being compounded with a normal kind of immediate release capsule, it's going to be very problematic, and it's going to significantly increase your risk of withdrawal symptoms, because basically very little of that drug will be actually you'll be exposed to in your circulation. So very important. So outro, for supporting patients that have severe withdrawal symptoms, we first want to stabilize patients. So very important, when, let's say, a patient has protracted withdrawal, which I'm sure is quite common and we see all the time, we first kind of determine what was the patient's maintenance dose over a number of years. Let's say that's 40 milligrams of Cymbalta. We'll slowly reintroduce the Cymbalta. We wouldn't go all at once to 40 milligrams, because we very often see paradoxical reactions where patients can actually feel way worse initially. So at a weekly cadence, we'll slowly introduce a Cymbalta until they feel a little bit more stable. We'll hold there usually for a month or two. We'll work with the patient, assess how they're feeling, and then create a comprehensive plan for slowly weaning that Cymbalta medication at a pace that's far slower than what they've done in the past. Just introducing, what we do. We do an outro where we personalize these hyperbolic taper plans. We closely monitor patients. We have multiple ways of multiple levels of involvement in terms of weekly monitoring, I think weekly visits versus monthly visits, asynchronous messaging. We're quickly ramping up our support for medicine, lifestyle interventions, therapeutic services. That we are building that, and very excited to basically be the best poised initiative to help people get off of this extremely challenging medication, Cymbalta. So we do, in terms of taper management, we make sure that patients are appropriate for this service and onboarding, make sure that they're eligible. We do our initial consultation to make sure that they're a good fit. We do a taper initiation visit, which is separate from the initial consultation, where we actually go into the nitty-gritty of how a taper would be implemented at a pace that's right for the patient based on a comprehensive history. And then we do close follow-up, of course, with asynchronous messaging and other support services to make sure that this works well for the patient. New York now. So we're quickly expanding our reach in terms of services. Now looks like 6 states, including New York. So we're rapidly expanding. So even if we're not available in your state or where you live internationally, we hope that our resources can be helpful for you. And we have a good deal of resources if you need in-depth information on tapering your specific antidepressant. Wanted to leave some time, at least, for Q&A. And so this is the fun part. I'm looking forward to Emma kind of letting me know what some great questions are from our chat. And I think it's a pretty international chat, too. I think you're muted, Emma.
I am muted.
Mm-hmm.
Yes.
Mm-hmm.
Okay, I'm going to try to speak loud again. So for everyone asking in the chat where we are located, that will be California, Texas, Colorado, Washington, Florida, and New York. New York as of yesterday. Very exciting stuff. Thank you. When we say that we're located in that state, it doesn't mean that we have a physical clinic. We are a digital platform, so telehealth. When it says that we're available in your state, it means that we have the legal opportunity to practice in that state. So you won't be seeing us in person unless we catch you on the streets. Or maybe if we do a meetup in your state soon, which will also be really exciting to do. But on that note, we could switch over to the other slide, sorry. And right here, for anyone that's interested in, because people in the chat were talking about getting started, if they're in the right city or state, you can scan this QR code. It should take you immediately to the eligibility part of our website, where you can take a quick survey that essentially makes sure that you're in the right state, and if you can schedule your initial consultation. On that note, I'm going to start going through some questions, but keep sending some into the chat. So Mona asked, this is my fourth time trying to taper off of Cymbalta. My question is, at what point in decreasing would you recommend holding for longer? And how long do you recommend that hold? My concern is that when I get to one bead, because that would be a 100% decrease. That's some good math, Mona. That is correct. But Bryan, do you want to maybe expand on how the hyperbolic tapering approach actually makes it so that people have more time to stabilize on lower doses as you get closer and closer to complete discontinuation?
Yeah. So generally, and it's individualized, is 4 weeks is usually enough time for the patient to, again, getting sciencey, reach that new homeostatic set point where they've stabilized on a dose. Sometimes it can take longer. But kind of honing in on Mona's question, it's one of the issues with counting beads is that let's say you have 5 beads left. When you reduce to 4, that's a 20% reduction, right? When you reduce to 3, it's like a 33%. Like the reduction is getting increasingly rapid, right? And we usually recommend 2.5 to 10% tapers for Cymbalta, which is why with compounding you can make those smaller reductions that are more challenging if you're using beads alone. Going from 2 to 1 is a 50% reduction. So those reductions are a little bit fast, even if you're at a very low amount of Cymbalta.
Mm-hmm.
So to summarize, sometimes patients need up to 8 weeks to stabilize, but sometimes it can be hard to finish up the process of tapering those beads.
Yep. And on that note, sometimes patients can taper off too quickly, which can also exacerbate or increase their chances of the protracted withdrawal. So Colleen in the chat wrote, what is the time frame you can try reinstatement when you find yourself in protracted withdrawal?
Right. So that depends on a number of factors. It depends on your maintenance dose. But typically, we might reintroduce the Cymbalta at, let's say, 10% of the maintenance dose, a test dose. We see how things go. If things go well and it's well tolerated, but you're still having significant symptoms, we'll further increase at a weekly cadence to get to your to the point where you feel better, or to your maintenance dose. Stabilize there for a month or two, and then taper more slowly.
Mm-hmm. And also on the note of protracted withdrawal, Tammy asked, if you're 5 months post-medication with a very fast taper, how do you recommend remedying potentially some of the side effects?
And I would need some clarification. Is that a patient who is still experiencing the same degree of withdrawal symptoms after 5 months?
She said she wanted to get back to her regular self of sorts, so that
Having
adaptation.
been off of the Cymbalta.
Yes.
Yeah. It depends on where things are trending, because sometimes if a patient's been off for 5 months and we see them, if they're trending positively in terms of recovery from withdrawal, because it can take a lot of time, then we may recommend close monitoring rather than reintroducing Cymbalta. If they're showing no improvement from the early acute withdrawal symptoms from Cymbalta, then we would consider a cautious reintroduction.
And another question from the chat. I'm wondering, does compounding processes disrupt the quote delayed release end quote aspect of duloxetine? And if so, what would that change in dosing frequency?
Yeah. So, and I've confirmed this with our pharmacist at UCI. So, if you were to use an immediate release capsule that's compounded with the bulk powder, it would be very problematic. If you use an enteric-coated capsule, then that's a delayed release mechanism, because it would resist the low pH, the high acidity of the stomach, and would be absorbed fairly normally at the small intestine, which is what you want. So that would hopefully be essentially equivalent in terms of exposure to the enteric-coated beads that are manufactured commercially.
And just to confirm in the chat, because there's a bit of back and forth, Cymbalta cannot be made into a liquid.
100% cannot be created into a liquid, because there's no way to protect that liquid from the high acidity environment of the stomach that would break down Cymbalta.
And something that Dan asked earlier in the chat that I also responded to, but I think could be valuable in the last few minutes, because a lot of people that are on one medication, psychiatric medication, are often on two. So if you're interested in starting to taper your antidepressant, or you're on two antidepressants, do you ever recommend tapering them at the same time? And if not, why?
We do not. We do not recommend two at once. The reason being is that it makes us hard to attribute symptoms to one specific one or the other. Often, and also it could be way too disruptive in terms of the patient's just what their brain is used to. Two at once can be very can be challenging and can make it hard to interpret what's causing what. What we do when we have patient on two medications, we have a couple different philosophies. Sometimes we taper the one that generally is we anticipate being easier for the patient to taper. Maybe it's Wellbutrin, or maybe it's a drug that the patient's only been on for 6 months or less, and then build momentum, and that can be a wonderful thing when you're moving on to that Paxil that you've been on for 20 years.
Yep. And Alex wrote another question in the chat. I'll read it out loud, and I also have a statement to make about it. What is the level of withdrawal symptoms that should be considered acceptable for someone that's continuing their taper? I've read guidance and support groups that withdrawal symptoms could completely subside before one takes another step down in their taper. But for me, my withdrawal symptoms have been mild compared to what other people have described. But is it ever safe to push through, and with what kinds of symptoms? Something that makes it even more confusing for me to navigate this is that it can be difficult to distinguish between Cymbalta side effects and withdrawal side effects. So we were both on Cymbalta. I think something that I want to mention as well is it's really difficult for me to admit that I needed help, and I really wanted to see that I tell myself that because I knew I was tapering, I could what we call white knuckle the experience. So I knew it was really difficult, but I kept trying to push myself to get off, and it actually made my withdrawal symptoms and my tapering experience significantly worse. I'm sure everyone's different, but I just wanted to put in a personal anecdote since this is the medication that I was on. I should have listened to my body. Someone in the chat earlier was also talking about taking a different medication to remedy the side effects of paraakaesthesia or nerve sensitivity of sorts. And I similarly mentioned that for Outro, we're not going to be putting people on a medication to maintain or address a withdrawal symptom on the tapering process. And that's also because it's your body's way of telling you that the tapering is a little too quick and that you might just need to pull the reins back a bit. This, again, was coming from me in my experience, but I should have listened and taken it a bit slower. So I don't know if you have any thoughts on that, Bryan, as well. Again, this also I'm no medical advice here. I'm not a provider or clinician.
No, thank you, Emma, for that beautiful summary of your experience. Withdrawal symptoms should be resolved before making the next reduction because withdrawal symptoms can be additive. It's an indicator that your body has not fully adjusted and created a new homeostatic set point before making that next reduction. So, and what level of withdrawal symptoms are tolerable? It's subjective, and it's a matter of the level of distress, and your overall level of functioning is a more objective marker. But we wouldn't want to make that next reduction before those withdrawal symptoms are resolved to minimal.
And for our last 3 minutes here, I'm looking to see in the chat, there's a lot of thank yous happening. So thank you guys for attending. We wouldn't be doing this if there wasn't such an explicit interest from you on having to get to know us and what we do and better identify what you're going through to help validate the experience, because it can be really isolating to be on an antidepressant, let alone trying to get off and not having your symptoms be heard, understood, and seen. For anyone else wondering, yes, we will be sending out the recording. The recording will have the slides, possibly not the one slide that the slides were down on, but I'll add that back in. I'll edit it, see what I can do. But you'll also have the audio from the webinar itself. And I encourage everyone to attend future webinars. We'll be having these weekly on Thursdays. You can ask your questions there. And yeah, that's everything from me. Bryan, if you have any closing thoughts.
No, I just wanted to thank everyone for joining and kind of learning about the nuances of Cymbalta, and just it's a word of reassurance that there is definitely hope for getting off of the specific medication. and we're equipped to help you with that.
All right. Thank you so much, everyone. I hope you have a lovely rest of your day and come into a great weekend.
Thank you. Thanks, Emma. Mm-hmm.